chest X-ray, CT, ultrasound, thoracic imaging in COVID-19 coronavirus infection. Rule 1. All signs of corona imaging are non-specific. Correlation with clinical picture is essential. Normal chest X-ray, CT not exclude corona COVID-19 infection. Coronavirus might still be present even person CT scan is normal. Imaging request. Sufficient information needs documenting in all imaging requests and all imaging referral. Department should work with local clinician to ensure relevant clinical information in all imaging requests. Imaging request. Suspicion of COVID-19 included in request. Infection risk impacts on how, where, when patient imaged. Raised white cell count, lymphopenia usually present in COVID-19. CRP unusual to be COVID-19 positive patient of CRP is normal. Relevant respiratory history, smoking history. Imaging CT or X-ray, role or no role? No role if patient not seriously ill and the PCR available. Role present for imaging to management decisions, to complication, for differential diagnosis. This role of imaging in coronavirus infection: management decisions, complications, differential diagnosis. Radiodiagnosis and clinical suspicions. Clinical suspicions is imperative in taking decisions for corona infections. If no clinical suspicion, radiology is non-specific and many other processes must be done. CT pattern in coronavirus infection COVID-19, we have 4 patterns: classic, probable, indeterminate, non-COVID, no COVID. Classic pattern, classic CT patterns in coronavirus infection, which have 100% confidence, characterized by what's called ground glass opacity. Ground glass opacity distribution: lower lobe predominant, peripheral predominant, multiple bilateral foci of ground glass opacity. But could be unilateral? Yes. If more than one lesion, could still be unilateral, but usually universally bilateral. This is for classic CT pattern of COVID infection. Ground glass opacity may present with other finding or present isolated ground glass opacity with no other finding. Which finding which must or may be present with CT pattern of classic COVID? Crazy puffing, peripheral consolidation, air bronchogram, reverse halo perilobular pattern. Peripheral consolidation and reverse halo perilobular pattern, diagnosing for organizing pneumonia pattern. This is crazy puffing and consolidation, ground glass pattern in classic COVID-19. What's meant by ground glass? We have 2 opacities in high resolution CT either ground glass or consolidation opacity. Both making whiteness in high resolution lung CT. Ground glass, its opacity which make haziness, replacing normal blackness of the lung, but not totally obscure underlying bronchovascular marking. Ground glass opacity, it is whiteness, but we can see this is bronchovascular marking which is present under this ground glass opacity, behind ground glass opacity, like glass, which allow us to see what is behind this glass. But consolidation is totally obscure underlying or background of bronchovascular marking. Ground glass in crazy buffing pattern, this is specific for classic COVID-19, but crazy buffing pattern can be seen in many other lung disease. Crazy puffing can be seen in hypersensitivity pneumonitis. Crazy buffing, which is mosaic pattern of ground glass, meaning area involved and the area is normal. This is crazy puffing. Area involved with whiteness, but neighboring to it, adjacent to it, black area, normal area of the lung. Mosaic pattern between affected and non-affected area. It's crazy puffing. Crazy buffing and the consolidations. Consolidation in classic COVID-19, consolidation in COVID-19 has also specific pattern. This is examples of consolidation. This is white area, whiteness, which you cannot visualize bronchovascular marking behind this area, totally obscure lung behind this whiteness. So, crazy buffing and the consolidation in classic COVID-19 infection. Ground glass opacity with reverse halo and perilobular sign of organizing pneumonia. Reverse halo meaning area of whiteness surrounding black area. Halo meaning that we found dense or white area surrounding by black rim or hypodense rim, but in reverse halo we found the hypodense rim surrounding by white area. This is perilobular sign of organizing pneumonia, ground glass perilobular sign. Bronchocentric consolidation. Consolidation, we talk about white area, totally obscure bronchovascular marking behind it. Bronchocentric meaning involve segmental, subsegmental bronchi, bronchocentric and irregular nodule. This is organizing pneumonia pattern. Reverse halo pattern, which is seen in organizing pneumonia in classic COVID-19, lucent or hypodense area surrounded by white or dense rim or merge. Perilobular pattern or fuzzy arcades, meaning striking arcade-like distribution of consolidations. Consolidation not present in lobar or lobular pattern, by present as arcade-like distribution of consolidation. This is what meaning by perilobular pattern, fuzzy arcades. Organizing pneumonia pattern in classic COVID-19 infection. Classic COVID-19. Peripheral ground glass opacities, crazy puffing distributions, mosaic pattern, affected area with adjusted normal area, organizing pneumonia, and perilobular pattern of consolidations, arcade-like distribution of consolidations. Ground glass meaning replacement of air in the bronchi or alveoli with fluid or infection pus in classic COVID-19. This is ground glass, meaning that in this area, air present partially replaced by fluid pus in classic COVID-19 infection. Classic COVID-19 chest X-ray bilateral peripheral airspace disease is suspected. Peribronchial thickening, consolidations, heaviness, ill definitions of peribronchial marking. Another CT pattern is probable pattern, meaning 71 to 99% confidence. Probable meaning less than 100%. Probable COVID coronavirus infection. What is finding in CT? Lower lobe predominantly mix of bronchocentric and peripheral consolidation. Bronchocentric meaning segmental subsegmental bronchi affected. Reverse halo perilobular pattern of organizing pneumonia. Ground glass opacity scars. Bronchocentric and nodular organizing pneumonia. Pattern air bronchogram but no ground glass. This is in probable COVID-19. So, what is main difference of probable COVID-19 from classic? No ground glass opacity. No ground glass. Indeterminate CT pattern of corona COVID-19 infection, less than 70% confidence. This pattern do not fit into definite probable or non-COVID, manifests above pattern, clinical context is wrong, suggests alternative diagnosis of interstitial lung disease or connective tissue disease of the lung. This is indeterminate COVID-19. Ground glass but must be differentiated from contrast, tissue contrast in CT and or dependent. We change the position of the patient from supine to prone, or a change factor, we found resolution into this is ground glass opacity. Indeterminate COVID-19, ground glass, patchy, non-peripheral changes, fibrosis with ground glass, complex pattern could be seen in other interstitial lung disease or connective tissue lung disease. Bronchiectatic changes. Indeterminate COVID-19 in X-ray in this case is unhelpful. This poor quality film non-specific for COVID coronavirus infection. Indeterminate COVID-19 needs clinical or clinic radiology review, fever, CRB, and especially lymphopenia would make COVID-19 more likely. Ground glass opacity differentiated from normal tissue contrast and or dependent physiological changes. Last CT pattern is non-COVID, no COVID, no corona infection. 17% confidence for alternative, like lobar pneumonia, cavitating infection, 3-impad, centrilobular nodularity, lymphadenopathy, fusion, established pulmonary fibrosis. Non-COVID-19 as this CT high resolution 0.6 mm lung rescan reconstruction, and when we do 8 mm MIB lung reconstructions, we found difference in imaging quality and in resolutions and in ground glass appearance. These cases of Burkitt's lymphoma, pancytopenic febrile 5-day with diarrhea, 3-impad, MIBS useful, and acinar COVID negative. This is we do initial swab, non-COVID-19. Non-COVID-19 following would be unusual in non-COVID-19 infection. Lobar pneumonia, cavitating infections, 3-embodied changes, and effusion. This is unusual finding in COVID-19 infections, which may be direct us to classification of non-COVID-19. Serial change in CT scan in COVID-19 patient. CT imaging chest, 62-year-old man with fever for 2 weeks and dyspnea for 1 day. Negative result of RT-PCR assay for the SARS-CoV-2 using a swab sample were obtained on February 3 and 11, 2020. Initially, examination CT scan done 27 January. We found multiple ground glass opacities bilateral lung. Next examination, next day, 28, we found enlarged multiple ground glass opacities, progressive course. Another examination done after 1 week, we found multivocal organizing pneumonia diagnosing for classic COVID-19 infection. Multivocal organizing consolidation. Another examination, last one, done at 13 February, we found a regression of the disease, partial absorption of the organizing consolidation. It's good news. Patient start to recover. We may finding in imaging scan even if COVID-19 infection still become negative. Normal CT scan can be seen in early COVID-19 infection. Don't exclude infection. CT pattern and the quantifying disease. CT pattern quantification of the disease in classic probable indeterminate group classified into mild or moderate and severe. Mild CT pattern up to 3 vocal abnormality, 3 cm in maximum diameter. Moderate and severe more than 3 vocal abnormalities or maximum diameter more than 3 cm. Difference between moderate and severe is subjective, conjunction with clinical assessment. CT pattern quantifying these in probable COVID-19. Pure ground glass opacity, score mild with up to 3 vocal abnormality, less than 3 cm in maximum diameter. Pure ground glass opacity with more than 3 vocal abnormality, maximum diameter more than 3 cm. Scored moderate or severe. Difference between moderate or severe is subjective. Vocal ground glass opacity mixed with early consolidation. Score moderate or severe. Diffuse ground glass opacity or consolidation with signs of architecture distortion. Score severe. This is CT pattern quantifying these in probable COVID-19. This example of CT reporting performa in COVID-19 guided by British Society of Thoracic Imaging. This is a recent cases, first cases seen in the United States in January 2020. BA and lateral chest radiograph done in 4-day illness and first day hospital for patient, no thoracic abnormality noted. This is normal chest X-ray in positive COVID-19 infection, positive corona infection patient. Next chest radiograph done in 22 January with day illness 7, hospital day 3, no acute intrathoracic plain film abnormality seen. This is next radiograph in illness day 9, hospital day 5. We found increasing left peribasilar opacity. Left basilar opacity, and this is arousing concern about presence of pneumonia. Last X-ray done in illness day 9, hospital day 6, stable streaky opacities in the lung bases, indicating likely atypical pneumonia. Opacity steadily increased in density over time. This is first patient with COVID-19 infection in United States. Chinese patient coronavirus patient. Coronavirus still present even though person CT scan is normal. We found ground peripheral ground glass opacity present in this true patient. A recent new patient in 2019 coronavirus, we found multiple, in this chest X-ray BA, multiple opacities scattered bilaterally in pose lung of consolidation, which impressive of organizing pneumonia in coronavirus positive patient infection. This is multiple patchy areas of pure ground glass opacity present in coronavirus patient. Ground glass opacity with reticular and or interlobular septal thickening. Patchy vocal over-rounded peribronchovascular subpleural opacities associated with reticulation and architecture distortion. Distribution of this is opacities in peripheral and posterior part of the lung. PCR polymerase chain reaction, which laboratory investigation done with use throat swabbing, transfer to lab, and DNA amplification. Polymerase chain reaction PCR throat swab concern reavailability. When demand increases, processing time significantly increase. China ran out of PCR testing kits, so implemented CT scanning as diagnostic tool. When testing kits of PCR in China ran out, it's depend on CT scanning as diagnostic tool. PCR sensitivity 60 to 70% and can give false negative result initially. Retesting patient precipitates. Ultrasound lung signs, P lines, pneumonia signs, pleural effusion signs. B lines, ground glass lung with alveolar pattern. B2 lines, coalescent ground glass pattern. This is chest ultrasound, multiple vocal comet tail artifact in interlobular septal thickening. Lung consolidation pneumonia sign in chest ultrasound, tissue pattern hepatization, subpleural echopore region or tissue-like echotexture, boundary or shred sign, reverberation echoes in the margin, air bronchogram sign, white air bronchogram sign. This is lung consolidation with air bronchogram white sign with tissue signs, hepatizations of area of alveoli involved by fluid in or pus in pneumonia. This lung consolidation, hyperechoic foci of air bronchogram within consolidation. This vary according to respiratory cycle, change location, size, and shape. Echogenic consolidation of airspace disease with highly echogenic branching linear pattern corresponding to air bronchogram in patient with pneumonia. Severe consolidation or hepatization fluid bronchogram in pneumonic patient. Pleural effusion 3 finding in chest ultrasound, quiet sign, sinusoidal sign, dynamic change fluid color sign. Sinusoid sign indicating free pleural effusion and the viscosity enabling use of small caliber. We do M mode to elicit this is sinusoid sign. Thank you for listening.